I will start my chat then. So I am Erin Elizabeth Elliott. And so some of my friends like to say triple E, but I prefer E cubed because that's nerdier. But that will come into play in just a little while. I have a little special treat for you. So, what I'd like to do is if you guys want notes or some of the blow-ups of some of the slides, like the effects on the human body, those types of things, please go to joinsleep101.com, joinsleep101.com, and I will send you an email with a link to a Dropbox, and it comes from my personal email. So if you want that, that's how you can get to it. And so just a quick review, I do practice in North Idaho, Coeur d'Alene area, even though I am in Tampa right now, and you can see my hotel room. But this is my partner. I've been at this practice for 19 years since I graduated, and our associate, and we really do have a lot of fun. Great practice, awesome team. So I did share this slide that T-Bone or Tarun Agarwal, he's one of my mentors, basically stating that, as we get out of dental school, we really do want to just like make money, pay our student loans, get efficient, learn how to talk to patients, get the general dentistry down. But there's no way I should be doing dental school dentistry 19 years out. And so I've added some things into my procedure mix to give me more time. And so some of those things that I've been able to do because of technology and my team and continued CE is really, I do 4 days of dentistry, if not more, in 3 days of work. Like I'm producing more than I ever have. And that's because I add implants, sleep, ortho, all of these things. But some of these also bring us emotional dentistry. And so to get patients like sleeping again and giving them their life back, every time I just say, I am so frustrated with medical insurance. We're just going to do fee for service, even though we understand medical insurance and we've been doing it. I'm just so frustrated with them. A patient will come in and just like, oh my God, I'm like, fine, we're gonna keep doing this. So really finding your why, but the professional satisfaction you get from adding some of these procedures is like no buckle pit will compare. So we also discussed the workflow. So to kind of put it down into 4 simple steps. Now I say simple, but not always so simple. But we must create awareness in our patients. There are certain dental signs and symptoms, even looking at their health history, we can identify patients that probably don't even know they have a problem. And that is because so many of the diseases or problems that obstructive sleep apnea, untreated sleep apnea can cause is treated by a pill. And so it's far too often that we never look at like, why are these things happening in your health? So creating awareness in our patients, but then getting them to a diagnosis. And I have a few different workflows for you to kind of look at is to get the patient to the sleep study. Once you do that, that is where the magic happens. All of a sudden they're coming in because their wife made them. And by the time we get through the testing and go over the sleep study, that's my favorite part, is nerding out and telling them their story with these numbers. They're like, oh my gosh, like I need to do this. We increase that value and create urgency that the patient didn't have before. And then the financials, we're going to go over some things on that. So you really should not be scared of medical insurance. Unfortunately, this is the thing that stops most dentists. And if you really want to have a program in your practice, we've got to figure that part out. Don't get stuck there. What I mean by program is, instead of dabbling or doing 1, or 2 appliances every couple months, we really want to create kind of like, honestly, this is what I'm known for, but we also just want to create that we're the experts. Obviously we love it, but we know what we're doing. And from the first phone call, patients can see that. It's not just me and an assistant thing, the whole office is involved. And then lastly, the treatment. And so many times the dentist, we like to start there. However, it doesn't matter what appliance you use or what treatment they do. if you don't have a patient to put it in because you haven't learned how to talk to them or identify them. So last time we did talk about awareness, but I'm also just going to briefly review kind of the stages of sleep apnea or the different types. And so primary snoring essentially means that the patient has been tested, they don't snore, and their sleep is not interrupted, or they do snore, they just make noise. Their sleep is not interrupted. Then there's upper airway resistance syndrome. A lot of these are the young, fit female, as Dr. Rouse would say. They're usually slender and just exhausted, maybe a little higher anxiety, higher heart rate, especially when they're asleep. And they're usually petite in clenchers. And that's because they are fighting so hard. They wake up at 1 a.m., 3 a.m., toss and turn, light sleepers. They are fighting to keep their airway open, and they're winning, meaning they are keeping their airway open at the cost of good sleep. And so what they have is a lot of arousals or sleep interruptions, an increase in brainwave activity. So if they actually were to get a sleep study, because most of the time they just get sleeping pills, and if they were to go get a sleep study, they would be told that they're normal. And so I have just a special place for these patients because so many times they're told they're fine when they're really not. And they need to be treated. We treat them with an appliance. There's other ways too, but this population is really important to help. And then obstructive sleep apnea, that's what we care about. And then there's something called central sleep apnea, in which the brain does not send the signal to breathe. And those patients are rare, but also ones that we cannot treat with an appliance. Our focus is on the upper airway resistance and obstructive sleep apnea patients. So just to review, obstructive sleep apnea is a physical blockage of the airway, usually in the soft palate and tongue region. Also that hyoid bone, that's kind of holds our throat muscles and tongue muscle. It's a free floating horseshoe shaped bone right in the neck that can be collapsible as well. So here's kind of a view of a full obstruction. You can see how large that tongue really is. Of course, we as dental professionals know how large the tongue is. And so that's collapsed back. It creates a terrible cycle of over and over again as we're sleeping, especially as we relax, our airway narrows. We may or may not snore. Snoring is not always the main symptom. But when that airway narrows to the point of collapse, is an apnea. So our oxygen desaturates, our CO2 levels go up, and our body says, we need oxygen. It's the number one drug our body needs. And so it interrupts our sleep to kickstart our breathing again with cortisol or stress, the stress hormone, so that the airway opens and it starts all over again. And then there's two types of apneas essentially. There's a hypopnea, which literally means less air. So what this is saying is that if you look at the very top line, that's the brain wave. The next line is airflow measured through a nasal cannula. And then the next three lines are the effort belt. So it's something that you wear around your sternum and it measures effort. So in this patient's case, you can see the airflow isn't flatlined. It's not completely gone. There's still a little squeak of air coming through. And then the brain and oxygen goes down and the brain says, that's not enough. So we need to kickstart the breathing again. And then the patient has some rescue breaths to kind of fall into another hypopnea. So the fact that there's still a little squeak of air is what makes it a hypopnea. So it's like breathing through a straw instead of a nice wide open airway. And then there's an apnea, which literally means without air, without breath. And here the difference is that you can see that the airflow is flatlined, it's zero. So the analogy that we use is kind of this water faucet. So if you think of the airway as a faucet, snoring shows resistance or turbulence. You can see that in the first one. This is from my friend Tony Swau. He's good Cajun. And then hypopnea is a little trickle of water So there's still some air coming through, but just not enough. And then apnea is a complete cessation of breathing. So in a sleep test, we measure how many apneas and hypopneas there were and divide it by the number of hours slept. So that puts us on the scale. And the upper airway resistance patients usually are like in that 3 or 4 range. And so they're told that they're normal. The guy who was part of creating this said this was just a starting point. It was never supposed to become the Bible. And so he regrets it. He spent the rest of his career, recently passed away, spent the rest of his career trying to get recognition and help for the upper airway resistance patients. 5 to 14.9 is considered mild. And saying that, even that description is wrong. He fought that too, because when you hear mild, it's so easy for patients to dismiss that. And the mild patients oftentimes are the most symptomatic. And again, it's because their body is still fighting and trying to keep the airway open at the cost of good sleep. In mild to moderate cases, oral appliance, when medical insurance looks at these patients, a lot of physicians, unfortunately, when they look at the sleep study, if they're mild to moderate, they can get an oral appliance first. Anything over 30 is considered severe, and they, according to medical insurance, have to go get a CPAP. However, I have treated a lot of severes. There's a lot of different factors that go into it. AHI is just kind of a arbitrary number in a way. Then, how common is this? If you think about how many patients are coming into your practice every day, so commonly we get asked, which doctors should I talk to, which physicians? And honestly, if you don't know what to do with that patient yet, you shouldn't be trying to get referrals from doctors. You should understand the workflow and get that down before you're asking for referrals. So you have plenty of patients within your own 4 walls, within your own population. In fact, you probably have 4 or 5 walking in every day, if not more. If you think about how many patients come into your practice every day, and you think about 20% of those, and honestly, I think it's more, because we do sleep studies at our course, and we do about 20 each course, and more than half of these healthcare professionals usually have some sort of sleep disordered breathing. And of those, the population over the age of 50, it's half. Then of all of those sleep apneics, 80 to 90% remain undiagnosed. And it's because like death certificates don't say death caused by sleep apnea. It will say heart failure or stroke. It's just like, I don't understand why it's not on their radar as the cause of many diseases and often an early grave. Here you can see of those patients that were diagnosed, tired enough to go get a study, tired enough to get the one and only treatment given to them, how many are actually compliant with a CPAP? And it's about 60%. So that's a whole other untapped population within your practice of people who have been tested and just couldn't tolerate the treatment. So when we talk about awareness, which patient should we talk to? And that answer does not need to be anybody and everybody, because the big thing is to get your team doing this for you. That's where the conversation should start. So you need to get the team on board and the team looking for this. But if you tell your hygienist tomorrow that they're going to talk to every patient about sleep, do you think you'll get excuses or pushback? What I would say is that you would make it a goal for every operatory, that includes restorative, to talk to 1 patient a day, just 1. That kind of avoids the overwhelm. It kind of overcomes some of the excuses you might hear. And as doctors, I know we have team members on here too, but as far as doctors go, you should not make this a 15-minute conversation with your patient, because your hygienist want their op. And so if you were to do that, then they would be more hesitant to bring it up. Therefore, what I usually do is say, you know what, I think Sarah's right. We see some of these things in your health history that are related to sleep apnea, and we would love to do a consult with you so that we can see what's going on. We can do a sleep test in the comfort of your own home, and we bill medical insurance, not dental, but medical. So let's get you back for a consult and we can go over all of that stuff. Just try to get in front of the patient's objections. And that took all of like 20 seconds. And it's very rare that a patient says no to a consult. But I kind of have an unfair advantage because I've been doing this a while. But even if they're hesitant for the consult, you've planted seeds. And if they say no, it's okay, because there's plenty of times where it's taken like 3 or 4 appointments, even 3 or 4 years before the patient said, remember when you talked to me about sleep? Like, I have a new girlfriend and I need to do something. You never know when those seeds are going to come to fruition. And oftentimes patients, when you talk to them, I always ask questions like, why now? And why didn't you get help before? They don't know where to go. They don't know who to turn to. Their primary care doesn't have time to ask them questions about this. We're the perfect people. We're staring at airways all day long and their health history, and we tend to know them and we see them more often. So we are the perfect people to be the gateway for helping them and getting them tested.
Erin, can I interrupt you here?
So it can lead to all of these issues. So increased risk of stroke, increased stress on the heart. Do you have any patients with hypertension? I made a big point about AFib and how most AFib patients are getting tested now, and their doctors are on them to get treated. You could have 3 heart attacks and your cardiologist wouldn't suggest a sleep study, but if you have AFib, you will. Congestive heart failure, even patients that are taking aspirin tells me they're concerned about their heart. People who are on antidepressants, anti-anxiety, people falling asleep in your chair, falling asleep in the waiting room or welcome room or whatever. They're not supposed to be called waiting rooms anymore. Moody people. Now, I wouldn't suggest saying you're grumpy, you should get a sleep study. Snoring or relationship discord, morning headaches could be oxygen deprivation, but they might even say that they have TMJ because they wake up with headaches. I'm like, oh, you have TMJ? I have me. You know that joke. People that have trouble losing weight. Anyone you know has trouble losing weight? And that's because cortisol can lead to visceral fat increase. There's 2 hormones, leptin and ghrelin, that are balanced in deep sleep. But if your airway's constantly closing off and you never get into deep sleep, those hormones are out of balance, plus your blood sugars are regulated. Oxygen deprivation plays a role in insulin intolerance and glucose resistance, or glucose intolerance and insulin resistance. So there's all of these factors going into why sleep apnea leads to weight increase, and then increases in the severity of the sleep apnea, and then it's hard to lose the weight until you actually get treated. Acid reflux or Gerd, most patients think that it's heartburn, but if you know someone that clears their throat a lot, hoarse voice, especially in the morning, or coughing in the morning, a lot of those are signs of acid reflux without it being actual heartburn. And remember that omeprazole and Prilosec and all those kind of drugs oftentimes are over the counter. So we need to be making sure we ask our patients what over the counter medications they're taking. So omeprazole and Prilosec, all those, I think they pulled Zantac, but a lot of those acid reflux medications are one clue. But also patients that take like melatonin or Tylenol PM or things like that, we need to be asking them, because that would also be a clue that they have trouble sleeping. And melatonin is actually a terrible sleep aid, by the way. And then ED, patients don't usually talk to me about it, but sometimes they do. If you're on the last one, I have a really funny slide on that. And then Nocturia. This one is a big like light bulb moment for patients, because so many times they think getting up and using the restroom several times is normal. They think it's bad prostate, getting older, drinking too much water because they're so healthy, small bladder, That's just what people do. It's actually not normal. I had a front desk that we treated, and she was like, oh my gosh, this thing's like voodoo. She goes, I haven't had a monster in a week. I wake up ready to go. And I was using the bathroom like 4 times a night. And now I don't get up at all anymore. Like, how crazy is that? So most people do not make that connection to sleep apnea. So even if you were to, I just went through a whole bunch. Oh, sorry, diabetes. Even if you were to just have your hygienist look at the day before and see which of their patients have these conditions, and they can choose one just to talk to. Hey, we now know that sleep apnea oftentimes is the cause of diabetes or hypertension. Have you ever been suggested to get a sleep study? Well, we have some. We are now screening for this. We would love to help. So another question is, if you relate it back to their medications, that's a pretty easy way to open it up, because that kind of hits them. They have to go to the pharmacy every month, all of those things. If you say you have a large tongue, that might not affect them as much. Do you wake up refreshed in the morning? Well, are you supposed to? Yeah, you actually are. And so I just say, you might not be getting the rest that you should be. We have this test that you take home so that you can see if we can rule something out called sleep apnea. I try to even avoid saying sleep apnea because people get a wall of defense. And then I also make it clear that it's a little machine that they take home. Because sometimes I'll say, oh yeah, we can do your test at home. And they look at me, I'm like, oh, no. It's a machine you take home. If I go home with you, that's going to cost way too much money. And we have them at our office so that they can get screened. So if you just look for those things that are medications and issues that they usually check on the health history, those are your patients of the day.
Erin, can you hear me? Erin, can you hear me? Oh, let me interrupt you a couple things. One is someone asked about melatonin not being a good sleep aid, because I know a lot of people that take it so they don't have to take maybe Xanax or something else, Ambien, right? So why do you say that?
Okay, so this is a little bit of my soapbox.
That's all right.
So melatonin is taken quite often because it's natural, right? It's not a prescription. You can just go to the pharmacy and buy it. Well, the issue is that it's a hormone. And so if you've ever been on any hormone treatment, that's not something you just take in a pill. Like, you have to use a cream or something that absorbs. Like, you don't just take hormones in a pill. And it's a hormone that comes from the brainstem. So you do not want to flood your body with exogenous sources. And in the same pill bottle, there was pills that had 0 melatonin and some that were like 3,000 times the amount that you needed. So you don't want your body to get used to external melatonin. But here's the thing about melatonin that's the biggest reason why. It's not a sleep aid. The reason that why we secrete it is to get our body ready for bed. It's a sleep initiator. It's not a sleep maintainer. And so, like, for jet lag, I should be taking it right now because I'm on Pacific Coast time. And that would help me kind of with the time change. So it's good for like short-term jet lag type things, but not every day for a sleep aid. It helps helps get to sleep, but not stay asleep. And you don't want your body to get used to external sources. So we talk about initiating our own, or encouraging our own, and it's all based on light in our eyes. The retina carries the message back to release melatonin. So you minimize blue screen. I think we even have a night mode in our phones. Minimize screen time. Make your room dark, and also a hot shower to a cold room. Our body temperature has to go down 2 or 3 degrees also as we get ready, our body's ready for sleep. So those are just some tools. but a lot of people take it because it's natural.
Yeah.
But it's really not good.
I take melatonin. It gives me crazy dreams, actually.
I hear that
That's
a
what,
lot.
you
I
know,
hear that a lot.
my naturopath said, yeah, you're probably going to have some crazy dreams. Because I take 15 milligrams. And it's like, yeah, I have these really crazy dreams, but then I remember them the next day. It's kind of fun, actually.
No dreams of, so it's interesting. I'm starting to put it together. I should do a research paper on this, but if you have a dream of drowning or fighting, then it might be sleep apnea. It's a very common theme within my sleep app patients.
Really? Interesting. The second question, I won't tell you whether I have fighting dreams. The second question is, a lot of people that try something new in their practice, whether it be Botox or whether it be fillers or would be a cosmetic, put brochures and put some sort of what I call planting seeds in their reception area and their operatories. Do you have that? So are people looking at that as they're in your reception area and then come back and say, hey, you know what? I looked at this and some of these are me, right? I mean, you recommend those kind of things?
Yeah. So T-Bone, I think, calls it subliminal marketing. So I do have that. I took it out here. So that, let's see here.
See, I'm a firm believer in this whole planting seeds. I should be able to walk in your reception room, and if you want to be a
I know what you
cosmetic
offer.
dentist, there should be pretty people, and there should be something that tells me you make people more attractive, right?
Yeah.
Versus scenery or flowers or something like that, right?
Yeah, and
so
I don't use questionnaires. I don't use questionnaires at all. We customized our health history. We ask these questions. And then the subliminal marketing is, I have something like this. And it says, ask your hygienist today for more information. So it's like the first part of a stop bang questionnaire. So do you snore, feel tired? Has anyone observed you stop breathing, or do you have high blood pressure? But more than that, we're working on some, I'm like, we have these TVs here. Why are we not using those? So we're going to do like a Google slide thing so we can feature, adult ortho, cosmetics, all those things. Because we do Botox and filler and all that stuff too.
I'm going to interrupt you again because I know I'm sure a lot of people have this question as well, right? So you didn't wake up one day and say, I'm tired of doing DO amalgams on 15 and molar root canals. I want to be a sleep lady, right? So what steps initially? Because I know we have a lot of listeners that are saying, you know what? Occasionally I'll make a sleep appliance from Glidewell, and sometimes I ask, sometimes I don't. So what steps did you take initially when you said, you know what, I need to incorporate this more into my practice versus just kind of a weekend warrior on sleep?
I have to tell you, it was 13 years ago. I was kind of all in from the beginning. Like, even when people told me this doesn't work in practices, I was like, oh, it will now that you just challenged me. But it was really like getting the form, getting the team trained so that like we knew what to do with the patient, figure out where to schedule them. It was like the details that we don't think about. When the patient comes in, what do you do at a consult? And then what do you do? So it was almost like creating a step-by-step workflow protocol to make sure we had all the paperwork and everything we needed. So it was getting into the details. And
so
then
what was it that prompted you to say, this is what I'm going to focus my practice on? I know you do implants as well. Lots of times people change their direction when there's maybe someone in their life died of, upper airway disease or hypertension or something, or they were diagnosed late, or their wife wears or husband wears a CPAP. What was it that, again, I'm going to go back to 13 years ago for you, but you're still young, so you can remember.
Yes.
What was it that you said, tomorrow I'm going to be a sleep doctor? At some point you had to make, if you're all in, something prompted you to do that.
I was born like a 70-year-old lady. My mom said, like, I would be like, I'm gonna go take a nap, even when I was like 4 or 5. It was never, bedtime was never an issue. I just really like to sleep. And as you saw, I like to sleep anywhere. So my husband takes selfies and posts me sleeping everywhere. So I like to sleep myself. And I didn't realize how common it was for people to not feel rested, to not have a good night's sleep. And so when I went to the course, my dad, who was a dentist, wanted to come with me. And I was like, okay, fine, but we're getting separate hotel rooms. And it's because of his snoring. And that's just what my dad did. Like, we didn't think anything of it. It's like the weirdest thing thinking back, that he had every sign and symptom. Yeah. And we just were like, nope, that's just what my dad does. And so what we discovered with the sleep test is that he had moderate to severe sleep apnea, and his heart rate was just bradycardic and 89 beats per minute on average when he was supposed to be sleeping. And I do think we've only been given so many heartbeats in this life. They shouldn't be wasted sleeping or doing Ironman. Yeah, that's just silly use of time. But when we treated him with an appliance, it was amazing. Like, my mom's insomnia got better. My dad was like, that's what it's like to have a good night's sleep. He's like, I didn't know how tired I was until I wasn't tired anymore, because it was such a slow progression. It became such a part of his life. And he didn't really see it happening. And we just kind of all lived with it. So being the person that helps uncover this, and sometimes being the only healthcare provider that brings it up, and sometimes saying, I told you so, but I never say that. But it is just like the detective work of it. No, I don't. But I love that. The pieces of the puzzle and putting them together for patients and uncovering that. That's a lot of fun. Yeah. And it's not that great.
I think what you said is kind of hit the nail on the head, is that we just assumed, especially if you're maybe a little overweight and you're a male and you're, past middle age, you're going to snore. I mean, that's kind of, people snore, right? You either snore or you don't snore, and there's no diagnosis. And I think, the cardiologist would treat all that hypertension with hypertensive medications instead of looking at the core issue. Have you found that the cardiologists have been open and aware that this plays? Yeah, I think
you could have, but like I said, with AFib, they are. They flipped a switch with that.
Really?
Sure.
And but not so much hypertension. I mean, your conversations with, yeah, it's really sad that they haven't figured that one out.
Well, some of it, I asked my primary care friend, I was like, why don't you send for sleep studies more? He goes, because if a patient comes in with 10 problems, I have time for 3. And then if I bring this up, then all of a sudden I'm keeping track of, did you go to the sleep lab? We get the results? Did you blah, 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 like more things? They are so burdened. So I said, tell you what, if you just refer them over to me, I'll take care of them from beginning to end. I get a ton of referrals every day, and we have a system. So we have a person in charge of calling on referrals. It's like from beginning to end, we have a system. It can always improve, but the doctors like referring to me because I send them letters and keep them in the loop. But then our patients themselves, I hear my hygienist talking to them all the time, because I've tested and treated my hygienists and their husbands. And so they know how to talk to patients about it too, and uncover these things. Just even talking about bruxing wear in a different way. I mean, it's transformed how we look at patients, and it just happened to really help our practice at the same time. Yeah. Like the core of it, and actually I'm going to share my numbers at the end here. You'll see that we're still a very heavy dental office. Sleep is just kind of like the bonus on top.
Thanks.
Okay.
That was perfect.
So with this is the little squares at the bottom. So I took out all the ones I don't care about. Like, do you care if your patient's having frequent diarrhea? Maybe. get the Depends out or something. But I took out these ones that I don't really care about and added these up in the upper left corner where patients are still paying attention, because these are all red flags as well of having potential sleep apnea. So again, put up the subliminal marketing because oftentimes patients bring it up themselves. Oh, real quick, notice I say tired, snoring. I also like trouble sleeping. It's not just about snoring. And I made that mistake when I first started. I was so focused on snoring, and then not using your CPAP. And I never say hate your CPAP or CPAP alternative. It's not using your CPAP, or can't take your CPAP with you, because we have a lot of hunters and fishermen and Harley and all that stuff. So we can help a lot of people in those categories. Then here's the Elliott evaluator. I do have that on the Dropbox, joinsleep101.com to get access to it. But there's obviously a lot of things here, but if you were to just focus in on a few things, you will catch a lot of patients. So bruxing wear, not all bruxing is sleep apnea. I'm not saying that, but it at least begs the question, how do you sleep? And oftentimes I find the severe, like the old fat men that you just know have like typical sleep apnea, because they say they sleep like a baby, and they probably do. And it's because their body has just given up. Their body's just like, screw it. We're just going to let our airway collapse. And they're super severe and they don't even notice. But it's those mild and upper airway resistance patients that are most impacted by it. So the clenchers and bruxers, acid erosion, scallop tongue. Scallop tongue is just little, as soon as you open, if there's little ridges on the side of your tongue, that's a sign. 70% shows 70% have a AHI greater than 5. And then just their airway, is it's red and swollen, battered uvula, narrow, way back there. So be looking for all those things. We always, one of my absolutes is we always do a sleep test before making an appliance. You cannot tell just by looking at someone. Don't just treat the snoring. There could be something way more going on. Okay, so how do we get a diagnosis? There's overnight in lab or in the hospital, or HST or home sleep test. So this is kind of what the PSG looks like. A lot of wires, sleeping in a strange place. This is what patients are afraid of, that you're going to send them to this. Or they were already sent and they just never went because they didn't want to go somewhere else. So with the advent of home sleep testing has become a lot more practical. Plus, there's a whole lot of tech coming out in watches and Fitbits and apps and all of this stuff, Oura rings, where it's really testing. It's not giving you the HI and testing where airflow, but it is giving you a lot of information. And so I think the medical world has to really keep up. There's fighting the dentist over this territorial, like, pissing match. Like, we don't want dentists to have sleep tests. I'm like, pretty soon patients are going to have access themselves, right? Just from going to the CVS. So the sleep study that I use mostly is the Medibite Junior. Actually, I have one here. I brought it all the way from Idaho for the course tomorrow. But essentially, it's like this little machine that sits right on the sternum, and this belt goes around, and it's going to measure your effort. Then we are testing pulse and oxygen, and then a nasal cannula that you wear to test airflow. So it puts all of this data together, and it's about $6 every time I send out the unit. And that is because this, and we use rechargeable batteries, and the unit itself is about $2,500. So from there, we take the data that it collects, and we have a sleep physician diagnose it. Another option, did I freeze for a second? Okay. That's what it looks like when it's on. Another option for a sleep test is this Watchpad 1. We use this quite often. It actually fits on your wrist and your finger, and that's it. The reason why, and it started by an app, the reason why I use this a lot is because it's disposable. It's one-time use. They are a little bit more expensive. I think like $60 or so. We use this because it's disposable. So if patients come from a long distance, or their chest is so large, we're concerned about the belt fitting, we send them with this. Or patients that might have trouble with stuff on their face. And my first reaction is always like, imagine a CPAP. And they're like, oh no, I can't do that. And then we do the Watchpad 1 and they get through the test much easier. So again, we have a sleep physician look at this. If you're concerned about that because of liability and dentist doing that, first ask your board of dentistry for what it says in writing, don't just call and ask to say you want to see what it says in writing. But I have some other options if you don't feel comfortable with owning your own. And then lastly, this is a big point. I saw it so much this week. It was insane. A pulse ox is not a sleep test. And I'll tell you what, primary care physicians especially commonly use these because they're free, they're cheap, they're accessible, and they feel good about themselves because they screened that person for sleep apnea. Here's the issue. It only tests pulse and oxygen. And I had so many examples where the oxygen never went below 90, but they had moderate to severe sleep apnea. Never went below 90. So they would have passed a pulse ox and told, oh, you're fine, you don't have sleep apnea, when in fact, they had severe or moderate to severe sleep apnea. Okay, so the big goal is to get a patient to say yes to a test. And in order to do that, we have to make it easy on them. If they are just kind of unsure about this anyways, we have to make it easy for them to say yes. And the way that we do that is owning our own, and we do a cash fee. We don't bill medical for that. My cash fee is $199. If they're an existing patient, I'll do $99 because my hard costs are about that. You can utilize a third-party telemedicine testing service. And what that means is that there's a company that we work with, super click of a button to order the test. They call the patient, then set up the telehealth with a sleep physician. They bill the patient's medical insurance. They get you a diagnosis, a letter of medical necessity, all the documentation you need to bill for medical, for the appliance. So we utilize them often for our patients. And then of course, I do still refer to our local sleep lab. Oftentimes they're booked way far out. The ball gets dropped in calling the patient. The patients then call my office looking for, how come you haven't gotten back to me with the results? I'm like, that's their job. So it's just really, that's how I started out. I was kind of following the rules per se. And none of my patients were getting help that I knew they needed because they made it so difficult on patients. So once we get the patients through the sleep test, we'll do a sleep test review. Oftentimes they're coming to me with the sleep test already, and it needs to be within 2 years. Some insurances are 1 year. So if a patient says, oh, I had a test and it said I didn't have sleep apnea, I have 2 questions for them. The first is, was it one you just wore on your finger? And if they say yes, and that's a pulse ox, that's not a sleep test. The second thing I ask is, when was it? Because sometimes they'll say, oh, like 5 years ago, which really means 10. And sleep apnea does get worse as we get older. So it's kind of like eyesight. So just because I went to the optometrist when I was 16 and I had 20/20 vision doesn't mean it's 20/20 now. But I think it still is. And then once we get the patient through that diagnosis, we will go over the sleep study. And that's where I think the magic happens. So I take all of this data and I can tell them, I think you would be a responder to an appliance, or you won't. I think you really need CPAP, and here's why. Notice that each time you have an apneic event, you turn over, see how you got up, use the bathroom these 3 times. Look what happened just before each time. There was a whole bunch of air closures or airway closures. Look how your heart started racing when your airway closed down. Look how your oxygen went down in the dumps when your airway was closed down. When they see that all in one little picture, that's where it really hits home that they need to do something about this. So we'll tell them you're a good candidate. We kind of go over informed consent, and I'll explain that in a moment. And then Lonnie will come in and go over the financials. So ahead of time, we have a breakdown of their insurance. Yes, I do use a third party. So we know just kind of what their deductible is, how much has been met, what their coverage is on this appliance. So we can give them an estimated out of pocket. And
Erin,
this is how
Erin, someone asked about some of the names of the telemedicine third parties that you use. Are you going to talk about that?
No, I had to take those slides off. So I use sleeptest.com. Okay. So the guy that owns that is pretty amazing. Just a good guy, and he does everything. Like, he has a lawyer, so he knows every state he does things the right way. So Ryan at sleeptest.com.
Okay, great. Thank you.
Okay, this is how most people at dental offices feel about medical insurance. Don't worry, the medical insurances feel this way too. Super frustrating. But in medical, you have procedure codes. But for anything you do, you have to have a diagnosis code too. So what I have here is the procedure codes. So at a consult, new patient, we bill out the consults too and follow-ups. So with the consult, the 99200 signifies a new patient. X is a last number. We do 2 if they have not had a sleep study. We do 3 if they have had a sleep study. And the cone beam and interpretation codes are there. And then for the home sleep test, we actually aren't billing medical insurance because it was taking so long for the pre-auth. And then there was like denials. It was just such a pain. We wanted to send the patients home with a test that night. And then you go through all of this hassle to get paid $150. So that's why we just do the cash fee. Plus, I don't really want medical insurance looking at me that close for doing the test. So at records, you cannot, whether you do impressions or scans, you can't bill for that. And then you can't bill the appliance until delivery. Here's another one of my absolutes, hard and fast rules. I do not bill until delivery. So that code for the appliance is E0486. And then any follow-up exams is 9921. That 1 signifies an established patient. And then we'll do a follow-up sleep test if the patient's moderate or severe. In mild patients, we actually, if they're doing better and feeling better, we don't really do follow-up tests because there's many reasons why. Maybe we can cover that at the end. Okay, so to submit for a pre-auth, this is the documentation you need. If you have these things, you should get coverage. So the diagnosis code for sleep apnea is G47.33. So that we get a diagnosis from a sleep physician. This sleep physician could be the one down the street, or it could be from in the cloud, or it can be from this third-party telemedicine company. So each of the workflows has a sleep physician that will give you a diagnosis because dentists cannot diagnose. Then we have the actual sleep study that shows AHI and all of those things. And then the codes that I just gave you. We have to show that we did a face-to-face. Each patient signs a CPAP intolerance form. Whether they've tried one or not, I have a spot that basically says, I'm using oral appliances first-line therapy. Epworth is kind of a worthless piece of paper, but it essentially asks a patient how tired they are. And so if the patient has mild sleep apnea, you have to show a comorbidity to get coverage. And so you can tell excessive daytime sleepiness is a comorbidity. However, you can't just say to the insurance, oh, this person's tired. You have to objectively show them. So the way that you can put a number to how tired they are is with the Epworth. And so we need to show an Epworth of 11 or more to be considered excessive daytime sleepiness. So every patient just kind of is an 11 or more. Other comorbidities are heart conditions, insomnia, mood disorders, hypertension, not diabetes actually. And then for every appliance I make, I have a prescription signed by some healthcare provider. Now, the sleep test is a sleep physician. This person up in the cloud has never seen this patient. So they're not going to write a prescription for necessarily a patient they haven't seen. So for every appliance we do, we get a prescription from an MD, a DO, a nurse practitioner, or a PA, someone that that patient has seen. If they don't have a primary care doctor, or they don't see the doctor, that's when we also use the third party because we can get a prescription. The diagnosis is different than the prescription. Just because they give you a diagnosis doesn't mean they're giving permission to get the appliance. So we send a letter and then that the patient was self-referred, has an AHI of 17. Could you please send a referral form that we're faxing to your office? So we send a referral form that's already filled out. The doctor or the PA or the nurse practitioner just has to sign. So we make it pretty easy on them because remember, they're busy. So if you have all of those things, you should get paid, but even then it can be frustrating. And this is exactly why we still use a third-party billing company to help chase down the denials and get the gaps and make sure the pre-auths are in and all of that. So before we send off scans, we do try to take scans whenever we can. We do not send them out until we have the pre-auth and a down payment of at least $500 from the patient. Now, this is a big point. Don't let insurance stop you. Even if we're not billing medical, I still get a diagnosis. I still get a prescription for the appliance because that covers you, so you're not practicing medicine. Even if you don't want to go through all of this trouble to bill medical, you don't have to. In dentistry, we're used to doing fee for service. We can sell clear aligner cases for $5,000 all the time. But the patients don't look at the aligners and say, these cost $5,000. They see the value in what the aligners will get them. And so when we talk about a cash fee for an appliance and not billing medical, something happens to the consumer. Like they really think that medical should cover every penny of it and that the appliance cost $2,500. So we try, I don't know what the magic is yet, but we try not to refer to the appliances costing $2,500 because they'll look at it and say, this costs $2,500. So we kind of talk about it as the therapy or the program that's kind of all encompassing. If you were to do that, we do have a cash fee where we still charge the $199 and we can roll it into the cost of the appliance if they move forward for $2,500. My biggest thing is that we have $500 down and then we can take payments after that. We use a merchant services company that was started by a dentist. It's called Apex Payment Solutions, and we have our patients on an auto draw so that they actually have 2 credit cards or debit cards written down, and they take out the money like at 12:01 a.m. when the paycheck first hits the bank. And we have them on that monthly kind of program. And if the first debit card doesn't work, it goes to the second. So as long as I have $500 down, we can make it affordable. The same patients go and buy $8,000 mattresses, but they don't know the mattress is $8,000. They know that it's, $80 a month. We need to be doing that same thing for our patients. And so again, we do $500 down and then payments after that. So even if you take medical insurance out of the equation, don't let that stop you. But we need to talk about the therapy and make it affordable. Again, these patients are getting clear aligner treatment for $5,000, but something switches when we're talking about a sleep appliance. Don't rely on the medical insurance as much. Don't focus on it so much. so that it doesn't become a stopping point for you, where you throw in towel.
Hey, Erin, can I interrupt you? I look at this and the whole deal that we still have to get the physician's permission to treat, when I think they're probably the least educated of this whole group. And that's a huge pet peeve of mine, just going to the physician and saying how, you said that they're seeing so many patients, they have so many things they've got to think about, but I think that's a kind of a cop out. At what point do you think it's going to be where we can make the diagnosis? And is the ADA, is organized dentistry helping us at all with this?
Ish. The AADSM is American Academy of Dental Sleep Medicine, and the AASM, it's like the sleep physicians just kind of kept like, here, you guys stay in your place right here. We're the important, smart people. You guys need to know your place. Well, we just had a president that really, Dave Schwartz, awesome guy. He really kind of gave us some, let's just say he stepped up to the plate to give us more of the peace and some more respect. The interesting thing is the sleep physicians on one hand are saying, we don't have enough people, we have a shortage in the sleep industry, all of these technology are going to put us out of business, we have all of these undiagnosed sleep apneics and we don't have enough people to treat them. But yet they're going to put all of the people that could help them and tie their hands and handcuff them. So we were sitting here sucking up to them, trying to get recognition, which I don't know if we'll ever get. Some of the younger sleep physicians actually were trained on appliances and actually listen to their patients and give them what they think the best treatment is and one they'll use. So I think it's getting better. The last 13 years I've been out in the medical community, so I feel like I've educated them, but they don't really want to talk about it that much.
Yeah.
So it's interesting. I just had a nurse practitioner who refers a lot, a friend of mine, and she sent me her sleep test. She goes, but I don't really have it. And I made a video of me going over the sleep test. I'm like, I already know, all this stuff. But I said, I'm just gonna go over this. She had mild to moderate sleep apnea and didn't even know what an HI was. So they really don't know a whole lot, but yet we do have to kowtow to them and get the prescription and all that. I am concerned about the Wild West with dentistry though, because then we're even going to lose more legitimacy. So it's one of those balancing acts.
So, I mean, you had mentioned a couple societies that are more sleep oriented. I mean, what's the ADA is, we all pay dues to this big, big elephant in the room that we don't see that they do much. Are they involved in this at all?
Yes. In fact, I actually, I'm pretty involved in organized dentistry, especially at the state level, because I feel like we do have a big impact. Like Idaho, we are impacting a lot of the laws, personal property, helping our businesses,
right,
and things. But the ADA does have a task force on sleep, and they put it in the policies that we should even be screening for it, even if we're not going to treat it, that we need to get more education and some pediatric and those guidelines. Right. So it's definitely on the ADA's radar. I think a lot of people told me this was just going to be a fad.
Yeah.
So I wonder if the ADA was just kind of ducking their head until it.
Yeah, they said that about veneers 25 years ago when I was doing that too, right? Yep. So where are dental schools with this too? Because someone brought a good point is, our young dentists, are they being educated? No. Not at all.
No.
Dental schools have not bought into this.
Some are.
Okay.
I know in Texas, there's the dentist that goes and lectures to the dental students, but it's not on the boards.
Yeah.
So
and it's not on the boards. There's nothing on that boards.
No, they have to. The students have to pass the board, so that's where the focus is.
Yeah.
And so they may get an hour or two. That'd be great if they did, but some aren't even getting that.
Yeah, and the kids aren't interested in it because they've got to make their requirements and do other stuff, and yeah. So where do you see, and I know that I'm keeping you from moving forward, where do you see us in, 5 years ago, we wouldn't have thought maybe we're even where we are now, right? So now that at least dentists as a whole, we understand it, whether we treat it or not, we understand that we play a role. Where do you see us 5 years from now?
I don't know. As responsible as I am, I don't future trip that much. I think that the technology, I think it's going to be direct to consumer sleep testing very soon. Even, and I wonder why the sleep physicians fight the dentist and not like the little internet.
Yeah, the ring.
Yeah, like why are they fighting us? I think that 3D printing is going to come into play. And I don't know how they're going to control that or FDA approve it. There might have to be a central place that designs them and then you just print them. Something like that. I think medical insurance is going to continue to make it hard on us. I don't know, that a lot of people are like, why don't you do sleep only? And I'm like, I get concerned long-term about coverage. And maybe there's a day I do go to fee for service, because right now I have enough good payers that pay above and beyond their cash fee that it's worth it.
Yeah.
But if you're just getting started, don't let that be like your stopping point.
Yeah. And you made a good point. I mean, I'm fee for service, and obviously insurance doesn't pay for my cosmetic or my full method. They'll pay for like 50% of $1 right? And you made a good point where, they'll go and they'll spend $8,000 for a mattress or $100,000 for a nice truck with leather inside that they don't want to spend $3,000 to save their life. Right. The other question too, considering most, and I think this, but I mentor 50 young dentists every year, and it's been an awesome experience. And a lot of those dentists either are going to or currently work for corporate dentistry, DMSOs or DMOs. Have they come? I mean, it just seems if I was the owner of a DMSO, I mean, I would want to get into this because I would think that, man, this is a huge cash cow potentially. Because people are not treating this. Are the Heartlands and the Aspens and the Pacific, are they embracing?
So my friend was tasked with teaching Heartland. There's a lot of moving pieces. And if you don't have a provider that's really believes in it and allows the team member to take it by the reins, like, that's when it really happened for us, is when I had someone full-time sleep and not going back and forth. So I know that they're trying. I think everyone's tried to cash in on sleep apnea. Everyone has. And it's not, I don't think it's as much of a cash cow as we think. However, it is worth it. And it has made a good impact, production or collection wise in my practice. Is made it worth it. But you would have to have just a system that is plug and play. And that's kind of hard to get if you don't have a doctor that really is behind it. And then team members that don't just like ignore it so that maybe you'll like forget about it.
Yeah.
And I have a sleep person right now that I have had almost 3 months. And she saw the light almost right away, and she sees the value in it. She's like, it's only $2,500 to save your life. Like, what are you thinking? Why wouldn't you do this? Yeah. So that makes a huge difference, I think.
Now, does someone ask, does Medi-Cal cover this at all?
No, I'm assuming that's Medicaid.
Yeah, Medicaid. Medi-Cal is California.
Yeah, it depends on this is not dental though at all. It's not dental. It's all medical.
So you can't bill it through, I mean, Medi-Cal or Medicaid covers a lot of medical expenses, especially for the elderly, but they can't be billed through this?
Oh, yeah. Like I'm signed up with Medicare as a DME provider, as a durable medical equipment provider. So there's certain parameters you have to follow, but we get paid right away. The supplementals pay above and beyond, like they pay, the F&G plans play really well. But in my region, Medicaid is different. So when I sign up for Medicare, I'm not signing up for anything dental whatsoever, nothing dental at all. It's just DME oral appliance. Medicaid, in my region does not cover an oral appliance, so we do not bill it. They'll cover a CPAP though.
Isn't that interesting? Like me, I toss and turn. If I wore a CPAP, it would be wrapped around me like a boa constrictor in the morning, right?
Mm-hmm.
I looked at that sleep study and think, I'd be tangled up. And if I did have to wake in the middle of the night to go pee, it's like, do I keep this on? Do I throw it down? What the heck do I do with this thing? Right. Yeah. So it's interesting, but anyway, keep going forward, because you got so many points, but stay with us this time.
I know, no video for you guys. Okay. You can still hear me, right?
I can hear you.
Oh, good.
I'll do this when I can't hear you.
I know, I lost the video though. So when I brought it back up again. So the treatment options, of course, someone's just like lose weight. Well, the problem is oftentimes it starts out as an anatomical issue, and you gain weight because, well, poor lifestyle choices, but also because you feel like crap. When you have untreated sleep apnea, you actually crave higher carbohydrate food. So you just because you lose weight doesn't mean you're necessarily going to get rid of your sleep apnea completely. However, losing weight does decrease the severity.
And we can't see your screen. If you have a screen, you're not sharing your screen. We can't see it.
Okay.
It's kind of funny you mentioned the weight thing. I think I told you last time that I had a yellow lab that used to sleep with me, and every time she got above 65 pounds, she snored. And I'm such a light sleeper. And as soon as I got her below 65 pounds, she wouldn't snore at all. So I'd be kicking her all night long, and the next day I wouldn't feed her so I could sleep the following night. Right?
Okay. So with the lifestyle modifications, it's about losing weight, but it also matters where you store your weight. So around your neck, and actually you can gain and lose weight in your tongue. And that's why if you lose 10% of your body weight, you can decrease the AHI by 30%. Positional therapy, that's where you get a patient who's usually severe on their back and more mild on their side. We can see that in the sleep study. And so oftentimes with an appliance and on their side, they're treated. And in a follow-up study, I think positional therapy is very important. So we can see what their AHI is on their side. And then we have to try to help get them on their side. Every patient says they don't sleep on their back, but they do. I would say I didn't sleep on my back, but it was like 80% of the night. So there's different tools to use for that. Sleep hygiene is just good sleep habits, no screen time, no TV before bed, no pets in the bed, some of those things. Pharmacological treatment, there's a drug trial that just showed some good promise there's a pill for that, for sleep apnea, that reduced AHI. Pharmacological treatment also refers to clearing the nose, so you get nasal breathing, so Flonase, those types of things. Surgery, there's a lot of surgeries that have been tried. That the only one that really works, we'll kind of go through some of the surgical options. CPAP, which we're familiar with, and oral appliance. I'm going to show you how that works. This is an option too. Now, obviously, this is old, and it's really not a joke. They actually did have this, but it says, this is why it's interesting. Stop mouth breathing and snoring, the causes of many diseases, and often an early grave. How did they know that back then? But we still don't know it today. But this also shows.
What year was this?
Oh, I don't know. It was back when there was only, I don't know.
Oh, $3 cash. That was cheaper than a gallon of gas. So that was 100 years ago.
Everything's cheaper than a gallon of gas. Surgical options. This was tried a lot in the 90s for snoring, and that's UPPP. It's where they cut everything out of the back of the airway. The problem is patients think they're cured, but they were never tested before or after. They're just quieter because they don't have as much soft tissue vibrating. Hyoid suspension is where they essentially put a screw here, wrap fishing line around the hyoid bone, and then put another screw in to tighten it, prevent the collapsing. They use radio frequency. I'll let you know how well that works because I had it. Tongue, you can just make the tongue smaller. Septal surgery, that's an easy, I refer for that one a lot because I use my cone beam for that reason. And that's just to get the patient breathing through their nose better, to make the appliance work better. That's not the primary area of obstruction. And so many young men say, I only snore because I have a deviated septum. And I was like, oh, from when you were fighting in high school? They're like, yeah.
A bar
And
fight.
yeah. And I'm like, okay, you can get your septum fixed, but that's not going to cure the problem. So the way I look at it is I tell the patient, hey, I saw this in your cone beam. The appliance is going to work well. If there's some residual snoring, this is what we would do next. It's almost like I'm setting expectations rather than giving an excuse later, like if they're still snoring. It's an easy surgery to recover from and refer for. And I'm like, plus your deductible's already been met. So let's just go get that done. Inspire is making some big waves. Your patients may be asking about that now because they have huge money behind it. Lots of advertising, bringing it to the consumer. Doctors are excited about it because it's like, if they have a hammer, they see a nail, so they like surgery. Essentially, it's like a pacemaker that's put under the rib cage. You have to turn yourself on it with this little remote control, and it attaches to your hypoglossal nerve. So if your tongue falls back, it zaps your hypoglossal nerve to bring it out of the back of the airway. So that seems like a little bit of a big surgery for it to maybe work. And then the granddaddy of them all, the one that does work, is the maxillomandibular advancement. It can change the way you look. It can help you lose some weight, probably, when your arches are tied together. But it does work.
Can I ask you a couple questions since it's right here? I know that breathing through the nose is, it's like the yoga, breathe in through the nose, out through the mouth, and you release nitrous oxide and reduce inflammation. So the whole mouth taping, I have a friend that tapes his mouth. And so the other day I thought, I don't think I could even sleep if my mouth was taped. So why are people mouth taping? And then I'm going to ask you another question.
So I just don't think it's good enough. Like, I don't think it's enough to treat the airway. The reason why it's a trend is nasal breathing does stimulate vagal activity, the parasympathetic part of our body. And that's why they do it in yoga. It picks up nitric oxide from our sinuses that hangs out in our sinuses to bring it to our lungs so we get better. It's basically a vasodilator, nitric oxide is. That's how it works with Viagra and stuff too. So we get better oxygenated blood. If we're breathing through a tube from here to here, it's much more collapsible actually than breathing through a tube from here to here. So we see a reduction in resistance and collapsibility. We also get humidified, filtered, and warm air, so it's healthier. In fact, when people during COVID, well, we didn't really wear masks in Idaho, but do you know how the people were making fun of people that wore their mask under their nose? If we had made a country full of nose breathers, we would have actually been much healthier. That was such a bad idea to force people to breathe through their nose. So mouth taping at night is good. I just don't think it's enough to treat the airway if the airway is in fact collapsing. So it can reduce resistance. It can be healthy, but plus, every time I bring it up to a patient, they look at me like I'm insane. So
I would look at you like you're insane.
Yeah.
Second is, I know there's some laser treatment with cold lasers and not like the night lays and things. What exactly are they doing? How have you had much experience with them?
So actually, I have a guy who just does sleep medicine in my town, and turns out I reached out to him to welcome him, and we're friends. And he has a night laser. And so I was like, this is awesome. Now I don't have to buy the attachment, because if I wouldn't buy the night laser just for sleep. If I was going to use it in dentistry, I would definitely get that attachment. It's really easy. It's like a 5-minute thing where you wave the laser, and it's essentially, and I could be wrong here, but it's essentially like shrinking the collagen fibers. And so it actually shrinks the soft tissue and tightens the soft palate quite dramatically. Totally non-invasive. You have to do like 3 treatments about 21 days apart. You can charge like $1,500. It's adjunctive. However, I still think it's adjunctive to make the appliance work better or remove some of that residual snoring.
So is that what, do you know what wavelength that laser is? Is that an erbium or an ND? It's not a diode.
I don't know, because Leia has a version 2 of their nightlights.
Okay. Good. Thanks.
Okay. CPAP basically just pushes air to blast open the airway to move all the soft tissue out of the way. It's not giving the body oxygen. So also with CPAP, to be compliant, do you know what it is? 4 hours a night, 4 nights a week. And you're considered compliant if you do it that little. That's like saying, you know, I got 70% of the decay out. We're doing good. So they just kind of lowered the bar. And even then they only get 60% compliance. So oral appliance basically postures the jaw forward to keep the airway open, prevents the collapsing of the tongue, and tightens the soft palate. So here's a review of our anatomy. And this is where I always point out that I got the highest grade in anatomy histology in my dental school class of Creighton 2003. And you know why I'm telling you this? Because no one ever asks, and I worked really hard. That's the only reason. Okay, so with bringing the mandible forward, what you can see is that it's going to bring the muscles of the tongue with it. It's also going to bring the hyoid bone with it, which is going to support the hyoid bone and prevent the collapsing. The other thing that it does is it drags that little pterygomandibular raphe with it. And if you can see what is attached to the pterygomandibular raphe, it's the superior pharyngeal constrictor muscle, the middle and the inferior. So what I'm saying here, that little, by pulling that forward, it's actually opening up the airway from the top to the bottom. And our airway muscles are circular. So when we bring it forward a millimeter, we're actually opening it up volumetrically. So I really hope this video works because this was like huge for me. I knew appliances worked. The research shows they work. My patients told me they work. But when I saw this visually, it's basically a patient that was put to sleep and then a scope was put down his airway. And so we could see the video. So in this next video, hopefully it'll work. You'll see the collapsing of the airway. You'll see the flutter of the uvula and here's some snoring. And then you'll see what happens when they bring the jaw forward. So there's the lungs right there. There's the lungs. And then here's the jaw thrust. So you can see that it opens up kind of like a flower, like the whole airway is open and prevented from collapsing again in quiet. So again, it opens the airway up volumetrically. And so when a patient asks, does it work? I always do this in the course too. I would pick on someone. I'm like, does this work? And they're like, yes. I'm like, well, that was convincing. I'm like, pretend I'm an engineer. Does this work? I think so. I'm like, no, I want the studies. So basically what you can say is that in mild to moderate cases, oral appliance and CPAP are equally effective. And even in severe cases, we see some resolution 69% of the time. So that's still a much higher rate than 30% that UPPP surgeries got us. So effectiveness, it is effective, little less in severe cases. Compared to CPAP, oral appliance wins in everything except getting the AHI under 5. So the goal actually for me with an appliance is to get the AHI under 10 and oxygen above 90. But when you look at symptom control and health benefits, oral appliance is equal to CPAP. So even if the AHI isn't under 5, we're still seeing good health outcomes. Convenience, acceptance, tolerance, adherence is better with appliances. And interestingly, there was a newer study just done on the affordability. CPAP is less out of pocket at the beginning compared to a custom oral appliance that's $2,500. But I say every appliance I use is 3-year warranty. So the patients, it's a lot up front, then it covers them for years. I have some appliances that are 8 years old and doing great. So the CPAP becomes equal to oral appliance like at month 6. And CPAP might be $800 out of pocket at the beginning, but then you need filters, distilled water, new masks, new hoses. Sometimes you're on a lease. So it be equal to CPAP or equal to appliance and surpasses it actually pretty quickly. But of course, the patients only see what it costs up front. That's why that $500 down is much more appealing than $2,500 right now. So when we talk about which appliances to use, if a patient says, I had an appliance and I hated it, it didn't work for me, I'm not going to get another, ask them what it was. Ask them if it was one they bought over the internet that should be not be used as a screener. And ask if it was one made by a dentist that does a lot of these, because commonly the dentist will just gravitate towards what is marketing to them. And so Glidewell says Silent Night, EMA, some of those, they're a little cheaper, tend to break. The Silent Night, I think, is even like 2 for 1 or something like that. And of all of them that were made, Detola told me that most of them probably did not have a sleep study, and the provider name and the patient name a lot of times were the same, like they were making one for themselves. Tab 3 has been around for a long time, but is not one that I make ever. I think it's actually pretty uncomfortable. So again, I tend to go for appliances that are digitally fabricated, CAD/CAM, milled or printed, and have at least a 3-year warranty. And that's because insurance covers every 3 to 5 years. So I want the patients reassured, and I want to be reassured that the appliance is going to last. But with the CAD/CAM milled, it's essentially we get the strength without the bulk. The old school acrylic salt and pepper is bulky, and we want as much room for the tongue as we can get, so we don't have to keep advancing to overcome that bulk. In addition, it's much stronger. We just don't see them break or crack like we used to. And if they did break or crack, we have to send the whole appliance back. And the patients are like, literally, we have to like, come on, give it to us. It's going to be gone for 3 weeks. I'm so sorry. Now with the digital workflows, we can just order another one. So I use the Herbst because I have to do a lot of Medicare, and Medicare has some strange rules that don't even make sense. So I do a lot of Herbst, and my Blue Cross of Idaho happens to follow Medicare guidelines. So it basically covers Herbst. So I use the Somnomed when there's edentulous areas, and then my favorite one is Prosomnus PH. And that's because there's 0 material on the inside. So even though it looks scary or medieval with those bars, it's actually very low profile. So I use it because I have to, and that's essentially why. It's good for side-to-side bruxers as well, people that like that freedom, like flattened canines. So Somnomed is kind of my appliance for edentulous areas, because with Prosomnus and Panthera, you have to have posterior teeth. Prosomnus Evo is one of my go-tos if I don't have to use Herbst, and that is because it is milled and it is strong, but now it has a little flex to it. This is the only material of its kind. No other company uses this in their appliance. So I get some flex with also the strength. And I have not had one of these break yet. And the way that you advance it is by changing out the trays that have different wing widths. I can't get into the weeds here on these. I apologize, but because I need to get to the end for everybody. And then last, the Panthera, that is nylon. It's really, really, they don't break. I mean, if you have a patient that breaks your dental work and grinds through everything, They make night guards now too, and we just don't even have to think about a warranty or people breaking or chewing through them. It's amazing how strong that material is and super, super lightweight. So when I approach a patient, I kind of look at this. Can I make a Prosomnus or Panthera? Evo and Panthera are kind of equal in my mind. We have to have posterior teeth, and we with the Panthera, you have to have, because the nylon material is not as exact as that Evo material, so you can't have short clinical crowns or kind of like no undercut type teeth. I would use a SomnoMed Avant due to edentulous areas, and then depends on if I have to make a herps, which a lot of my patients do, I use the brand based on how many teeth they have.
Erin, can I interrupt you? I'm gonna throw a little bit of twist at you. So I'm not a sleep guy, right? But we do a lot of full mouth rehabs, and something that we never thought about 5 years ago was the whole looking for ways to open the airway at night, which is grinding down these teeth, right? So if the brain is trying to open the airway at night and it's destroying dentition because it's posturing forward, and correct me if I'm not right, posturing forward, it's moving around and it's grinding teeth because it's trying to open the airway, right? I mean, we use a lot of NTIs in my practice for primary clenchers, and the NTI, and I know you're probably familiar with that, right? For those that aren't, there's a discluding element, which you can only hit in the anterior, but it gives the mandible complete freedom to move forward. So at what point, I mean, these appliances, and I've done some, snore guards, quote unquote, that lock the patient forward or keep them forward. At what point, if we put them, because I've had these NTI patients that did sleep studies before and after the NTI, and they were in the normal range with an NTI because the brain could posture the mandible forward. At what point do you think that the brain will compensate so that we don't need to lock them in forward? Did my question make sense?
Yeah. So actually, just by the way, FYI, I build NTIs into these appliances if they're clenchers. So if
I think that's really important.
Masseters here, and then put your front teeth together and clench, it doesn't get the power. And so I will build what's called discluding elements into the appliances for clenchers. Okay. Now it does deprogram and decompress the disc, allows those muscles to relax. I cannot tell you what level or what point.
And my question would be just, is that now the brain can say, you know what, I can slide forward on this discluding element, and it's basically moving the mandible forward. Does the brain need a mandibular appliance to lock it forward, or is the brain in tune enough that it's going to
self-titrating?
Yeah.
I don't know.
There hasn't been any studies on that at all.
Not that I know of. I'm going to the big AADSM meeting in a few weeks.
Ask someone, because we use ND. I don't do traditional night guards. We do a lot of NTIs on clenchers, and it's amazing how many will say, you know what, my wife says I don't snore since I got the NTI. I hear that daily. Yeah, which means their airway has changed, right?
Yes, and they probably sleep deeper and they don't toss and turn. A lot of clenchers are those upper airway symptoms. 1 a.m., 3 a.m. are kind of the clues there.
Yeah. Okay. Anyway, I don't interrupt. I was just curious about that.
I'm not necessarily a T. Okay, so here's the contact info for them. Again, if you go to joinsleep101.com, I have these notes as well as some blow-ups of some of the other graphics. So when we take bite, you basically, we need to give full arch and a protrusive bite. The way that I do it, there's fancy machines that help you. There's everyone that does their own bite comes up with their own bite way is like the only way you should do it. But basically, I like this SOM gauge. And the reason why I like the SOM gauge is because there's a little portion that lets you change the vertical. So we basically use what's called a snore test, and that's where we go through a variety of verticals with the ramp as well as protrusive movements, and have the patient snore. That was pretty good.
That was good.
And then we put them in a protrusive movement and have them try to snore. And all of a sudden they're like trying to snore, and they're like, wow, like that, I breathe better. So it's pretty amazing how powerful that tool is. And even if the snoring doesn't go away, that sets proper expectations. Like, hey, we may need to do a little bit more to get you fully quiet. However, can you feel yourself breathing better? And they say, yeah. And then over time, when they actually get an airway, that tissue gets stronger and healed. So the effectiveness of the appliance does increase over time. Okay, so let's bring it all together now. Traditional medicine is broken. If you refer out, you might get them in a year. That's if they even come back to you and didn't give up in the process. So I love that graphic on the bottom right. It's like the general practitioners, dentists, and specialists all working in perfect harmony for the patient's betterment. We get them back for a consult. You're not going to win them all, and that's okay. But if you can get them to the test, that's where the light bulb moment happens. This is kind of a sample of the workflow in my practice. The HST review, financial arrangements, records, imaging, we do all of that pretty much in like 40 minutes if we have to bring the patient back. Otherwise, we schedule extra time at the consult if they've had a sleep study and do it all in that appointment. Then we do the delivery, about like a 1 to 2 month or 1 to 2 week follow-up, and then about 1 month we do a follow-up test. Again, if they are mild, we don't. This is kind of a list of all the things we do in a consult. We have a little PowerPoint, we show a little cartoon, meet Todd, Sleep Better Northwest, if you Google that. And you also have to Google Air Baby, since you didn't get to see it, and it's amazing. So we kind of go over what sleep apnea is. It's amazing to me how little the patients know because the doctors don't explain it. They're like, I was just told to go here. No one ever explained it to me. And then when I go over their sleep study, all of a sudden they're like, whoa, okay. I didn't know all these things. But the biggest thing for me is finding their chief complaint. What is motivating them? Why are they even seeking help? That's what we need to speak to. They don't care if they're going to die. They just want their wife to stop nagging them. So you really need to find what speaks to them. Are they proactive, or like they want to stay healthy, or are they tired of feeling tired? So that's kind of how we help our patients. We kind of go through which appliance, have them all send all the paperwork and get scans and take a bite. So when it comes to the team, the whole team knows how to deliver a home sleep test and talk to patients. They have enough, they've talked to their friends and family enough that they've had enough practice. With hygienists, our goal is to find the patients, at least one a day, and get them to say yes to a consult. The administration team, no matter what day it is, it's their first day, we teach them how to schedule consults, deliver the paperwork to the patients, and when they come in, we collect medical insurance cards. So they're kind of already in the habit of doing that. Even if they're not a sleep patient yet, we still collect medical cards. The assistants deliver and adjust appliances. If they can do night guards, they can do sleep appliances very easily. But I do have a sleep champ. She hasn't had time for the professional photo yet. But she's kind of the one in charge. She does the consults. She kind of is the admin too. So she came to us for a front desk position because she didn't want to be chairside. So she loves the fact that she gets the best of both worlds. And she's pretty much her own boss and own provider. So Stephanie is my insurance biller extraordinaire, and she helps on the back end of medical insurance. She's my detail person. She makes sure we have everything back before we send out the scans and that the medical insurance will in fact pay. So we work in tandem together. If you are treating sleep apnea and not doing as much as you want, this is kind of our way to improve our numbers. So if you're actually tracking your numbers and you want to get to, let's say, 5 appliances a month. If you want to get to 5 appliances a month, how many people do you have to talk to about finances? What is your case acceptance when it comes to sleep? Let's say we want to get to 5 a month, so that number down at the very bottom is 5. Let's say we have to talk to 15 people. That's a third, 33% case acceptance. So if we talk to 15 people, how are we going to get 15 or more people diagnosed? You'd think that number between diagnosis and finances is equal. However, if you are catching some severes, you are going to have to be referring them off for CPAP and further examination. So let's just say 18 there. So how many people to get to 18 people diagnosed do you need to talk to from there? So if you're not getting the numbers you want, you can diagnose yourself basically of where the issue is. Are you picking the right patients? Is your hygiene team not know how to talk to them where they understand? Are they talking about the wrong things, the things that don't matter to patients, that wouldn't motivate them? Are you choosing the right patients for diagnosis? Are you making it, maybe you're not making it easy enough to get the test. And then when you're talking finances, if you're like, well, I think it's this out of pocket and insurance might cover it, we don't know. Does that instill a lot of confidence in the patient? So you can find out where the issue is in this workflow to improve. And so then you can get to the numbers you want, get better. Are you making payment plans? Are you going over the sleep study with them in a way that they understand that's meaningful to them? So there's a lot of ways to kind of figure out what you can do to improve. So lastly, I'm going to leave you with this, and then I know we have a few minutes. Just real quick, the dark blue on the top is sleep collections. Basically what this graph shows you is each time we added the technology, the implant procedures, an associate, we now have a prime mill and a second prime scan only for sleep and ortho. But you can see that even during the 2020 year, we were still collecting medical, even when we were off for 5 weeks. We were off for only 5 weeks. But yeah, I collected, was it 655,000 last year, just in sleep alone. So it can be a significant part of your practice if you get the workflow down. So things you can do is consider changing your health history, kind of making sure you're asking over the counter, looking for clues that the patients may need help. Start training your team on dental signs and symptoms and anatomy. Even if you were to break it down to the 4, or let's say 5 most important, these are what they would be. Show them a scallop tongue. Show them what it looks like. Make sure you're looking back in the airway when they're doing the oral cancer screening. Is there bruxing and where? You can take photos of that to show patients. Start collecting medical insurance cards, because once you start billing medical, we know which payers are good and minimize out of pocket. So then if it's like $250 out of pocket, patients might say yes a lot easier than $2,500. And we know which insurances pay well. You can make a list of previous night guards. You can check the health history before the patient even comes in. Even if you were to focus on hypertension, antidepressants, acid reflux, and diabetes, those are all the candidate of the day. And are you taking photos and using cone beam to show airway? And so that's easy for patients to jump and say, oh, that's why my dentist cares. They can see the airway. And then decide your sleep study workflow. You need to make it easy for patients. And then this obviously wasn't enough. It was a quick overview. So start talking to patients so it becomes comfortable for you. So you're not stumbling over words. So that's kind of where I'm. Just a few minutes to spare for questions. And again, if you want some of the notes and resources, this is where to go.
Yeah, and that was awesome. And I'm glad we didn't have too much technical problems.
Yes.
You did great. I love your energy and I love your excitement. And it's so similar to when you talk about how you integrated sleep, how we did cosmetics, right? You start with your health history, right? You ask questions on your health history, so that your patients have to ask before they even meet you, or they have to answer before they even meet you. You're planting seeds and you educate your staff. I mean, that's the bottom line, whether you want to do implants, sleep, and you do that so well. There's a lot of questions about, and this is something I would like for you to talk about. There was a question early on about the whole workflow. Oh, we lost her.
I'm right here.
At what point do you get the physician involved? So your patient says, yeah, I'm having problems. You do a scan, you do a health history, and you do a sleep test. So go through your workflow. At what point? So you do your sleep study first, then.
Yeah, we'll bring them in for a consult. Sometimes, even if they come in for a filling, we'll like move rooms to the sleep room.
Okay.
So that, because we're going to be building medical, I want them to be in a different frame of mind. So we will do, let's say we send them home with the sleep test, we get it back the next day, we send those results to get the official diagnosis. I'll go over the sleep test and all of that with the patient, but during that time when we're getting all of the pre-auth and everything ready for the patient in the background, I send a letter that basically says this patient was self-referred. They have an AHI of 17. Could you please sign the referral that's been faxed to your office? And so we essentially fill out the referral slip of ours, send it over for them to get a signature. That's how easy it is. And it's not just in my area. Doctors are busy. They like the fact that all they have to do is sign and we'll take care of it. I do get referrals from physicians too. So but if I'm just going from a patient in my practice, I'll just say this is a patient of record. We noticed these issues and noticed this like dental conditions. These are what was on the health history. They did a test. I don't have to say where that test came from. And it showed an AHI of 17. Could you please sign the referral?
Okay. And you're getting well, after you establish a relationship with the physicians, right?
No, there's a ton of doctors that I have never even met. And in their notes, like they'll even refer me patients now. They're like, told patient to go see Dr. Erin Elliott. Sometimes it's spelled Aaron because they haven't met me. Go see Dr. Erin Elliott. She does a lot of these. This even said she does a lot of these. Like I've never even met them. Yeah. It's not just having the reputation though. They just sign it because they don't want to be bothered with it. Yeah. If there's a problem when you're first starting out, I'll coach the patients. Oh, you see Dr. Ashley. Okay, so she's not the easiest. You may have to go in there and get this signed for us. Okay. But she doesn't always respond to the faxes. We'll give it a couple times, but we may need to get you to help. And if you put the patient on it, they'll get it signed.